All right. So, as you can see, the two videos, they're short videos, so they don't take very long. So you can watch those. I would play them now, but the YouTube will not sound on my computer, and I haven't figured that out yet. And I know that there's a way of doing that, but I just haven't done it yet. So you can watch that in your own time. So one important thing that we really promote um, after the delivery of a newborn is skin to skin, it's called. When we place a newborn on mommy's tummy or mommy's chest right after delivery. And we do this uh, for many benefits. The two most important systems that are at the greatest risk for a newborn are the respiratory system and the thermoregulation, or they're the thermostability or instability of the newborn. Okay. So when we do skin to skin, not only does it help keep that baby warm through conduction of heat from mother to baby, but it also gives some stability to the cardiopulmonary system, the lungs and the heart. Okay. So we place baby on mother's chest, and we initiate breastfeeding right away. Baby has reflexes, sucking reflex and a rooting reflex. So these reflexes will direct that baby to want to breastfeed right away. It's a great time to teach breastfeeding as well, because we can show mom positioning, and we can show her what we mean by the term latching. Baby's getting a good mouthful, so that the nipples don't get sore and so that the flow is going to be more adequate. Okay. And then the bonding, of course, that takes place. So if a mother chooses not or cannot breastfeed, at least she can begin bonding in that dyad relationship, it's called. So once that baby is born, we usually wait 1 minute before we clamp the cord. It's called delayed cord clamping. And then in that 1 minute, we're going to be drying that baby and putting baby on mother's chest. Okay. So the drying is to prevent heat loss through evaporation. So we're going to dry the baby, remove all the wet blankets, put a hat on the baby. All right. Suction in the mouth first, suction the nose. There's always some amniotic fluid and mucus in the mouth and the nose, so we need to clear that out. And we do an APGAR assessment after the first minute then. Okay. Baby's born on chest, dry, covered with a hat, suction, clamp the cord after 1 minute, and do an APGAR. Okay. So there's a lot going on in that first minute. Okay. Any respiratory distress of a newborn, any heart rate that's less than 100, we need to get the high-risk team in there, the neonatologist, respiratory, and extra help from the NICU nurses if there's some respiratory distress going on. We'll do a brief assessment, and those are assessments for respiratory status, apical pulse, just brief skin color assessment. Look at the cord. Once you clamp it, you can actually see a cross section of the vessels that were inside the cord. Remember, there's supposed to be one large umbilical vein and two smaller arteries. Okay, so look and see how many arteries there are. Occasionally, there's just one artery. Okay, so make sure you assess. And then we're going to collect blood from those vessels for blood type, RH status, and ABGs. Just routine assessment. The first 2 hours of life, that's what we do. And we also then will give vitamin K. Okay, APGAR scores. You have to know the APGAR scores. It's standard routine OB. And so it is something that you just need to memorize. So APGAR is named after a physician named Virginia APGAR, and she came up with this very simple tool that is standardized across the board that we can use. So A is the appearance of the newborn, and that's about the color. Okay, is the baby blue, pale, or hands and feet blue and the rest of them are normal color? Or is the normal color pink or normal dark skin color? 2 points for good coloring and no bluish or darker coloring. So that's just a skin color appearance of your newborn. The pulse, apical pulse. Is it absent? No points for absence. If it's over 100, that's a 2-pointer. Okay, so we want baby can have as high a score as 10. Okay, 7 to 10 is acceptable. Okay, if the heart rate is below 100, we'll give it 1 point. And then, of course, 0. 0 for floppy or no reflex activity. Okay, no reflex activity, no response to stimulation. When you suction the mouth, the baby doesn't react to it. So that would be a 0. If the baby pulled back just a little bit or had a grimace on their face, it's a little effort, but not much effort. We want a baby that fights us. Okay, so we would only give a 1 for the G, the grimace, the reflex activity. A is activity. So that is just simply, are both the upper extremity and the lower extremity flexing and extending? We want them to be flexed, both of them, in a relaxed position. Okay, we want them flexed. That means the neurological system is somewhat intact. Okay, so activity, active, moving around, flexing those arms and legs, they get a 2. If they're not really active and they're just kind of there, laying there, but their arms are flexed, that we give a 1. And of course, no flexion if it's extension. If you ever see a preterm baby, severely, extremely preterm, you'll notice that their extremities are extended. Okay, they don't even have the reflex sometimes to flex their knees. And then, of course, respiration. Okay, we want to hear vigorous crying. So when we suction the mouth and then the nose, we want that baby to really react to us, and we want to hear some good crying. The good crying is going to help that cardiovascular system adjust to a different pressure system now. Okay, and we'll talk about that. So that's the APGAR. Okay, so we do it after 1 minute, and then we do it again at the 5-minute mark. Okay, so a 7 to 10 is good. If it's below a 6, some moderate distress. If it's a 3 or below, that's severe respiratory distress. Okay, so after 2 hours, we do need to go ahead, and if we can do it within those first 2 hours, we'll do it. But sometimes mother is bonding with baby. We really don't want to disturb that. So we do need to go ahead and get some erythromycin gel in those babies' eyes. Does anybody know why we do that? Why do we put erythromycin gel in the eyes?
Is that for chlamydia?
Infection for mom, birth canal.
Yeah, but it's not chlamydia. Which infection would it be that mother might possibly have?
Gonorrhea.
Gonorrhea. Yeah, gonorrhea. We can treat gonorrhea topically in newborns. It is a state law, federal law, but patients do have a right to refuse. The women, the mothers or the fathers do have a right to refuse, but it does help prevent blindness. So good client education. We can discuss with our clients during labor or even before going into labor that some of the things to expect after baby's born. We do that, and then we also give an injection, an intramuscular injection in the baby's thigh of vitamin K. So why do we do this? Anybody know why the baby needs a vitamin K? right away.
Clotting?
For clotting, yeah, clotting. The baby is not able to clot. The prothrombin level is not going to be activated to produce platelets. So why is the baby not have adequate platelets? Why can't the body produce platelets yet?
Phenylketonuria. It doesn't produce.
Okay, so it's what it is the newborn intestines don't have any bacteria until they have been feeding for a week. Okay, so after a week of bottle milk or breast milk, then their intestines are able to produce vitamin K, because vitamin K is made in our body by our intestines. Okay, microorganisms in our intestines. Okay, we also consume vitamin K, but the most of the vitamin K is made by our bodies. So once the baby has been eating for about a week, then we know that their platelet levels should be sufficient, because they're made by the liver. The liver's immature too. Okay, so just some things that are pretty typical for different gestational ages. So a late preterm baby, a baby born between 34 and 36 weeks, they might have more difficulty with respiratory distress or apnea. Okay, temperature instability, more common in our preterm babies. Hypoglycemia, preterm. Hyperbilirubinemia, preterm. And feeding difficulties. Early term, 37 to 38 weeks, maybe some hypoglycemia, especially if mother is a diabetic. Transient tachypnea of the newborn, TTN, not uncommon. That's just a retained fluid from the intrauterine life, especially babies born by way of a cesarean section. During labor, vaginal delivery, the baby is descending and being compressed. So that excess lung volume is being reduced. The fluid in the lungs is being reduced during labor. But if we're doing a C-section, the baby doesn't have that benefit. So the TTN, you're going to see probably more so with C-section babies. And we're prepared for that, okay? So post-term babies, we're thinking mainly increased mortality, not morality. Let's see if I can change it. Mortality, because the placenta is old, less amniotic fluid, more injuries, large baby, meconium aspiration, because they probably will experience fetal hypoxia during labor if it's a vaginal delivery. So meconium aspiration, and then tachypnea. Okay. Also, hypoglycemia is not that uncommon in a post-term baby. So we could add that in there. Okay. And general assessment of a newborn. You don't have to know head to toe assessment of the newborn. We're focusing mainly on those first 2 hours in this class. Now, you will probably do a little bit more with pediatrics, perhaps. So we're going to assess a neurological function. So we assess all the reflexes, suck reflex, rooting reflex, swallowing and breathing. Newborns are what we call obligate nose breathers. They always breathe through their nose. They don't use their mouth. As adults, we do both. Okay, so we don't ever want to cover a nose up of a newborn. Okay, the reason they need to be obligate nose breathers is because when they're feeding, they're breathing, sucking, and swallowing kind of coordinated in a coordinated fashion. The younger the baby, the lower the gestational age, the more difficult they have in this coordinated reflex activity. So while they're drinking if you've ever fed a baby, you'll notice how much they're breathing through their nose as they're sucking and then swallowing. Next week, when we talk about some high-risk babies, the babies with neonatal abstinence syndrome, the babies that were exposed to drugs during pregnancy and they are delivered, some of their coordination isn't intact because of the exposure to their brain to those drugs. And so they have difficulty with coordination of swallowing, sucking, breathing. So they have some feeding difficulties. You can look in your text on gestational age assessment. Just look at it for interest, not necessarily tested specifically on that. Vital signs, heart rate, normal heart rate. Once we get over that first 30 minutes, get beyond the first 30 minutes, 110, 120 to 160. Respiratory rate, anywhere from 30 to 60 is normal for a newborn with some apnea. As long as that apnea is less than 20 seconds, it's okay. So you do need to monitor. If you notice your baby having some apneic episodes, make sure you're timing them and maybe do a good assessment and see what's going on. Temperature, anything below 36.5 is concerning. That's too cold. So 97.7, nothing lower than that. A baby that gets cold because of the environment is at risk for going into hypothermic stress, which demands energy that they don't have. So they can actually develop metabolic acidosis, okay, ketoacidosis. Normal weight for a newborn, 2,500 grams to 44,000 grams. Any baby over 4,000 is considered macrosomic or above the 90th percentile, big baby. Small for gestational age means what it says, gestational, if the baby is born at 38 weeks, their gestational age is 38 weeks, but they tend to be a little smaller than what you would expect. And sometimes that's like someone who's smoked nicotine or nicotine patches, drug use, high blood pressure, things like that, poor nutrition. Large for gestational age, the opposite. Okay, like a diabetic baby. Both of them are at risk for hypoglycemia. Okay, so it's really important that we educate our mothers, our clients, the importance of feeding these babies within the first hour or two. And then if they're breastfeeding, every 2 or 3 hours max. You don't want a breastfed baby to go beyond 3 hours. We're talking about the first couple of weeks of life. Okay. So we do the height, the length of the baby, the height of the baby, circumference of the head, circumference of the chest. Head is usually a little bit bigger than the chest. Okay. If it's asymmetrical growth, you're going to see maybe the head the same size as the chest, or babies that were exposed to Zika virus or cytomegalovirus, which we talk about next week. Some of the viruses that babies are exposed to, we see some microencephaly, smaller heads. Okay. And then cephalohematoma, we're going to talk about that in a minute. Intracranial pressure, if more than 2 centimeters. So we're looking at a good head assessment, and which we'll talk about next. Any questions about any of this so far? APGAR, we're going to do a little bit more than this, but I just want to do a brief early assessment. Okay. So what is going on with it, with our newborn and transition to that extra uterine life? What's going on? It's just hard to believe that such a small creature can adjust from relying on mother for glucose, blood flow, oxygenated blood flow. And the way the blood is being circulated through the fetal body is different than an adult. Remember, it bypasses the lungs because baby doesn't use the lungs until right after delivery. So what is going on that stimulates respirations in a newborn? How does that happen? It's just amazing. So let's do a question. See if you remember this. Okay. So you're getting ready to give your newborn, you're a nursery nurse, and you're getting ready to give the newborn a vitamin K, and the mother asks you why you're giving vitamin K. What would you say? What's the answer?
Or 4.
Number 4? Everybody agree with number 4? Well, number 1, huh?
Yeah,
Number 1, most mothers have a diet deficient in vitamin K. Not necessarily. No, you don't hear too much vitamin K deficiency. And the newborn has no vitamin K stores. That's not true. Vitamin K promotes the synthesis of prothrombin by the bone marrow. Is that true or false? Anybody know? Anybody remember? False. Yeah, Emily's saying, even though she's muted. What produces prothrombin?
Liver.
The liver. Yeah, yeah. The liver cannot break down bilirubin without vitamin K. True, false?
False.
false.
False. Yeah, yeah.
So it's not-
False. It doesn't need vitamin K to break down bilirubin. It needs a enzyme that the liver has. Okay. The newborn gut does not produce vitamin K for the liver to make prothrombin for at least 7 days. That's the right answer. So Mitchell was right the first time. So 7
I'm
days
second
after
guessing myself.
feeding, yeah, 7 days after being fed, there's enough bacteria in that gut now, the normal flora that can produce vitamin K for the liver. Okay, so then the liver can make prothrombin, which provides for platelets and clotting ability of the newborn. So if you know anything about Jewish history, back, the Bible tells us that in Jewish times, they did not circumcise their little boys for 7 days. They had figured out that if they tried to do it earlier, the babies bled and bled and bled. And then they figured if they waited till after 7 days, they didn't bleed as much. So they started the tradition. Actually, I think the Bible tells us God told them not to circumcise before 7 days. So after they started circumcising after that 7th day, because then they knew the babies wouldn't bleed as much. And it's based on the information we now know that the liver can't make any coagulation factors without vitamin K. The gut can't make vitamin K without food. Okay. All right. So thinking about nurses, care plans, and priority strategies, interventions for our newborn, we have to think about what risks they face when they're delivered. Okay, so establishing an airway is number 1, even for an adult, right? The circulatory changes, and then also thermostability, not allowing that newborn to get cold. Okay, the newborn cannot regulate its own heat. It tries to generate heat, but it uses so much energy to generate heat, and this baby's not been fed yet. So we're talking about those first couple of hours after delivery is critical. They depend on the external environment to provide heat for them, just like a cold-blooded, what do I say, reptile relies on the environment for heat. Okay, it doesn't have internal thermal regulation, so it relies on the outside. And then some behavioral adaptations of the newborn. Sleep-wake cycles. They go through different cycles at the beginning, while they're kind of asleep, but they're not completely asleep. And then processing the stimuli that they're now being stimulated with in the environment. They've not had to do that. So lights, touching, sounds are more clearer and louder to this baby and the things that they see. And then bonding, that dyad relationship. What can we do as nurses to help our clients understand the importance of bonding for newborn well-being? And this doesn't always have to be with the mother. It can be with the partner, okay, or the father. So the transition to extrauterine life is modulated by the sympathetic nervous system. So I don't know if you've learned in med-surg, you probably have about baro and chemoreceptors. Have you learned about those? That kind of regulate blood pressure. It's controlled by the central nervous system. So if they sense that the level of oxygen is low or that the amount of carbon dioxide is too high, it stimulates respirations, right? Deeper breaths, heart rate might increase, okay? So newborn, when they're delivered, they should be alert, okay? They've been through a lot. They should have spontaneous startles. That's a mature nervous system. Heart rate is going to be anywhere 160 to 180 for at least 30 minutes, okay? After that 30-minute period, they're being slowed down a little bit, okay? So heart rate might drop then down to 100, 120. Okay. Respirations, they're still working to get rid of that extra fluid. So you might hear some crackles in their chest. Okay. Grunting and nasal flaring, maybe so. Only for the first 30 minutes to an hour. We don't want to see those after an hour. Okay. If we do, then there's something going on. So we talked about after delivery, after 1 minute, we delay the clamping of the cord. And when we do, I don't know if you remember me talking about it way back in week 2, but the circulatory pulmonary systems are at low pressure during fetal life. Okay, we don't need high pressure. We've got adequate blood flow coming in through the umbilical cord. And it perfuses the entire fetal body, except for the lungs, okay? So once we clamp that cord, that blood pressure in that lung increases. The intrathoracic pressure actually decreases a little bit. So that allows for lung inflation and perfusion of the lungs, which begins the gas exchange. So those chemoreceptors and baroreceptors now are kicking in, telling that baby to breathe. Because we cut the oxygenated blood supply off. So the baby has to breathe now, okay? The ductus arteriosus, the duct that bypasses the blood away from the lungs during fetal life, begins to close right after delivery and should be closed within 24 hours. Some other factors that make a baby breathe: it's cold, they'll breathe more. Touching a baby, physical sensory factors. And then sometimes with the extra fluid in the lungs still from congenital malformations, heart defects, or just immaturity in the surfactant level isn't high enough, there might be some difficulty with respiration. So let's talk about respiratory distress. Let's see. You can look at this later. You don't have to know the periods of reactivity. Okay. So signs of respiratory distress: any respiratory rate below 30 or above 60. Okay. Below 30 or above 60. And of course, any apnea that occurs that lasts longer than 20 seconds. Nasal flaring, grunting, stridor, retractions of muscles. So normally when you and I are breathing, or when a person breathes and they're not having any difficulty, you're not going to see the use of intercessory muscles or intercostal muscles, you might say, subclavicular muscles or subcostal muscles, those respiratory muscles that help expand the chest. If you see retractions, in other words, you can really see them contract, and this picture shows it right here. Let me make it bigger. Right here, you can see the retractions in that picture. That means the baby's in distress. They can't get their chest to expand for air exchange. And that's a sign of respiratory distress. So any kind of retraction. And another sign would be paradoxical respirations or seesaw. The chest and the abdomen should be rising together during respirations. If there's seesaw, there's distress going on. Okay, so nasal flaring, grunting, stridor, retractions, seesaw respirations, apnea beyond 20 seconds. Those are signs of distress. And you can also, to try to remember those, you can memorize wet frog for those of you who like mnemonics. Wet frog is a way of remembered signs of respiratory distress. Acrocyanosis or cyanosis, which is which? What's the difference between acrocyanosis and cyanosis?
Acrocyanosis is just the outer limbs and it's normal. Actual cyanosis is a sign of hypoxia.
Okay, so normal or abnormal cyanosis is the bottom picture. It's the oral membranes. The lips are bluish. That's a hypoxia. Not adequate oxygenation of the blood. And this could be a respiratory difficulty or it could be a heart defect. Acrocyanosis, like Emily said, is hands and feet or arms and legs. Anybody know what causes bluishness of those extremities? What's going on? Why?
Low oxygen.
Yeah, the circulation is not mature yet. Yeah, it's not about inadequate oxygen. It's just about perfusion of the extremities with oxygen that might, or blood that's not completely oxygenated. So just poor circulation. So you can just rub them and swaddle the baby and that will help. But we do deduct 1 point from the APGAR if they have acrocyanosis. And here's some pictures of congenital defects that cause respiratory distress. Esophageal malformation. Sometimes the esophagus might be connected to the trachea. So whatever they put in their mouth and swallow goes into their lungs. So you're going to see cyanosis and respiratory distress in these babies. You'll probably see vomiting as well. Hernias, diaphragmatic hernias. Hernia is a weak muscle, right? A weak muscle that has thinned out to the point where something can actually protrude through it. So a hernia is a muscle, a weak muscle, and a hole develops. So a diaphragmatic hernia is a hole. So the contents of the abdomen actually can press up and enter the mediastinal cavity around the heart and the lungs, and that causes respiratory distress. So we talked about the pressure changes when we clamp the cord. Increased pressure then reverses the shunting, okay? So the blood pressure in the left atria now increases, and that closes the foramen ovale, the opening that's normally, that is there during uterine life, okay? There's that foramen ovale, it's called, where the blood is shunted from the right to the left. Now with the blood flow increasing in the lungs and the pressure of the blood going up, that left atrium then increases in pressure, and that closes that hole. And the ductus arteriosus is the same thing. So all the shunts that were taking place during intrauterine life are closing. Okay. Foramen ovale closes the quickest. And then the ductus, and then the venous duct, the venous duct closes and becomes, most of them become ligaments. Okay, you don't need to know where the PMI is, but the baby's heart is more central. A newborn's heart is more central, and at the fourth intercostal space, the apical pulse, instead of the fifth. Okay. So this explains the pressure systems. So the fetus is considered with a low pressure system. There's right to left shunting. Okay. Lungs are non-functional. There's a lot of pulmonary resistance. Okay. And decreased systemic resistance. So decreased blood pressure in uterus, in uterine life. Once that baby is born, we clamp the cord, it becomes a higher pressure system. Okay, so we've got the blood flow changing up. The lungs are functional now. The pulmonary resistance actually decreases and the systemic increases. So it's the opposite, so that the lungs can function and gas exchange can take place for the newborn. And the baby, him or herself, now can be independent of mother, providing its own oxygen and circulation. You don't need to know the specific pulmonary and vascular resistance changes. Just understanding that the pressure changes are what allow the functioning of the baby. So after delivery, we're going to assess during our initial assessment, that after that 1 minute, apical pulse for a full minute, like you would any cardiac patient, right? We never do a peripheral pulse for a heart rate on a cardiac patient. We always do apical, right? Yes, we need to assess peripheral pulses, but we need to document the heart rate based on the apical pulse. Okay. Delayed cord clamping increases blood volume to the newborn. You're allowing the placenta to continue allowing the blood to flow into the baby if you delay clamping for a minute. It increases that newborn's blood pressure. It helps decrease the risk of some complications that can occur with a newborn, like low blood pressure, anemia, and neonatal necrotizing enterocolitis, some of those other things. So improves perfusion, okay? But the one disadvantage, they have all these extra red blood cells now. So they might have a little higher bilirubin count, which is easy to resolve. Any persistent tachycardia or any persistent bradycardia signifies a problem. So tachycardia is usually anemia, low blood volume, hyperthermia, sepsis. Bradycardia is usually associated with a heart defect, heart block, hypoxemia. Usually, heart problems are congenital malformations. Okay, and usually we can attribute those to rubella, drug use, diabetics, or other prescribed drugs. We don't see very many heart defects in babies. Usually it's a respiratory problem. So some clinical signs of a baby with a heart defect, and they're not necessarily seen on a fetal echocardiogram, you know, during the antepartum life, during surveillance when we're doing ultrasounds. And we don't always notice a defect. Our machines aren't that good. Some of them are, but as we know, it's not diagnostic until they're born. So we might not even recognize them right after they're born. But any respiratory distress could be from a heart defect. It could be. And it has nothing to do with the inability or insufficient amount of surfactant. It might be a heart defect. Cyanosis, of course, pallor, poor feeding, irregular pulses, wanting to sleep a lot. I had a friend who had a baby, and this was many years ago. This was back in the mid 80s. I had a neighbor who had a baby, and I'm thinking, that baby doesn't look right, doesn't seem right. I had this intuition, and my friend was telling me that he just wants to sleep all the time. And they didn't diagnose him with any problems in the heart in the hospital, but he ended up having what's called a tetralogy of Fallot. He didn't have the energy to eat, and that's why he slept all the time. He did not survive. So tetralogy is just one heart defect that is sometimes seen. Tetra means four, so there's four things wrong with the heart with tetralogy, and you will probably learn about this in pediatrics. There's an opening between the right and left ventricles, so there is a shunting that takes place from left to right. That's not good. And the aorta is actually overriding not only the left atrium, but also the right ventricle. The right side of the heart is hypertrophied, it's enlarged because it's trying to push blood into that pulmonary artery against a stenotic area, you can see. So pulmonary stenosis, ventral septal defect, overriding aorta, and right ventricular hypertrophy. Those are the four. You don't have to know this. It's just interesting that with a baby with this problem is going to have some cyanosis because it's not getting adequate oxygenation. The blood is being mixed in the heart. So let's talk about the one of the most important things, other than respiratory status, the thermogenic system. How do we generate heat? Well, you and I can shiver, right? We can shiver, we can sweat, we eat, we have energy to make heat. We can move, okay? A baby within those first couple of days doesn't have that same, I mean, baby can move and can generate some heat, but it can't compensate if we let it get cold, if we have it in a cold environment, okay? So they can go into cold stress or easily. So there's 4 ways they can lose heat. And these are things that every nurse needs to know who works in the nursery. Every mother needs to know, that if there's a draft in the room and the baby is not covered appropriately, they can get cold. So convection is a flow of heat away from the body surface because the cool air is moving it away. Okay. So we make sure we dry our babies. We put a hat on and we cover them with a warm blanket. Okay. So that takes care of conduction, evaporation, and convection. Okay. So convection is a draft from a window or some cold object, a fan in the room. Evaporation, we know what that is. If the baby is wet, babies are wet when they're born. They lose heat from evaporation. Conduction is if we put something warm against something cold, direct contact. Heat's going to be dissipated to the colder object. Okay, so we don't want to put a nice warm baby on any cold object. For example, a scale. We put blankets on scales to help diminish heat loss. So conduction. Radiation then is being near something that's colder. Okay, so the heat's being drawn away from the baby to the colder object. It's an indirect transfer. And this is just a picture about what happens if a baby gets cold. They're trying to generate heat. They're trying to use calories to generate heat. They can't shiver. So pulmonary constriction, they become acidotic, hypoxemia occurs, respiratory rate goes up, metabolic acidosis. And a newborn's kidneys are not mature, so the kidneys cannot even buffer the acidotic blood. So hypothermia, anything below 36.5. And you'll notice babies that are cold will actually curl up like this to try to conserve heat. Full-term babies have what's called brown fat, and they can get some energy from brown fat to help generate some heat. But preterm babies don't have that. So the renal system is immature. So babies that urinate their first or second, third urination is pretty clear. It's not yellow. Okay. And then the GI system. And we're getting ready to run out of time here. So you can look through these slides. You can look through the GI. And we will be covering this stuff next week too when we talk about high risk. So you can study these slides comparing male and female as far as assessment. And then the caput and the cephalohematoma definitely is our high risk. Okay. Okay. I do want to have some time to remind you that you have a teaching plan. Anybody have a question about the teaching plan? You know what you're going to do? If you want to send me a copy and you write it out on a piece of paper or type it out and send me a copy via email, and I'll let you know if there's something missing or, you know, maybe give you some guidance. I'll be glad to do that for you before you submit it, just like you do for your OB calculations. You have discussion 3 this week to do, and you have the healthy newborn case study, which should help you with this week's content. So take your time and do a good job on it and learn from it. Okay. And then your grades will be ready Friday. If you want to know whether you passed or not, I'll be glad to let you know. For the most part, everybody did improve on this exam. So if you want to know if you passed or not. Just, I'll be here and let you know in the chat if you want to know approximately what your grade was. I'll give you a range. If you
Yes,
want
I
to know.
would.
I want to know.
I want to know, Professor.
Please.
I do too.
Yeah, please.
Me too.